The structure was first was the learning objectives. So I think I can start there because I have made the slides, so it's better to tell that one because I'm toiling some sweats for that one. I want to start this with what is the objectives today for this this training bifurcation session. Just if you look at why it's not coming. There you go. Oh yeah. Now you can lower the lights. So which one? The lights there, lights of this one or this one? Which one? So if you see this picture, and if I go with this one, not too many years, 2 decades back, like 20 years back or 25 years back, what your seniors used to do at that time? Oh my gosh, there's a LED and also a huge diagonal branch which has a disease. What you used to do? You were confused and just you have these lesions, these 2 lesions only. So what you used to do, you have to go and beg to the surgeons at that time. I'm telling when I was a fellow. And the surgeons were very much happy to treat that one because the bifurcation policy. And if you see this one, then no question, you are fleeing like this bird. You are fleeing from the scene because you are not even looking at anything. That go to the surgeon. This is also another left main lesions, bifurcation lesions. So, thinking about this bifurcation PCI, it's now, after 2 decades, it's not a hypothetical issue anymore. And that's why you need to be mathematician, you need to be physicist to do a bifurcation. That's the most important objectives. And I want to thank EBC also for this one. Back in 2004, they have started this journey and made it a religion to make the bifurcation PCI beautiful. So that's the purpose of this session. And you see, for left main, because I'm going to talk about the left main. So left main revascularization, it was also class 3 before. And then later on, this, you see the guidelines evolution. So red color is getting yellower and then greener also in the long run. And that's why the left main revascularization is not always a class 3 red signal now, because of this evolution of the techniques. And we have calculated more articulated techniques, more improvised devices for bifurcation lesions. And no more we are reluctant to face a bifurcation lesion now. So that's the learning objectives here. But we need to know and we need to understand very methodically this bifurcation. And also know the physiology, know the inside story of the bifurcation in non-left main and also beyond left main bifurcation, in left main and also beyond left main bifurcation, then to choose which way to go and gain the expertise specifically dedicated to bifurcation PCI. So that is the today's objectives of learning. And now I'm going to talk about the left main one, and then Dr. Gruzman is going to talk about the non-left main one. What is the... This one is finished. Yeah, now the presentation. No, I will it. Meeting আছে lecture দিচ্ছি So the left main one, where is which one is given? The same one? Okay. So you see this, I'm showing you some of the name of the trials, the landmark trials you are seeing here. These trials has led us towards the left main revascularizations is possible, reliable, feasible, and also patient-friendly. That's what I'm telling, in terms of TLR, in terms of the composite endpoint, the primary outcomes in every senses. But we know that, everybody knows, we are facing about 4 to 10% population with the left main nowadays. And left main is a different animal because of its unique origin and also the unique branching also. And it has, you see in the lateral walls, like in the distal left main and also the proximality. The disease prone is because it is the low endothelial shear stress area. So it's how you will approach this one. I'm not telling it's crystal clear now still, but still it is confusing, sometimes very hard to predict and very difficult to plan sometimes, I know, in real world. If we go from basics here, which Dr. Guzman has started really, that we have to define first. We have to understand that what is bifurcation and where is the bifurcation lesion here. Actually, we're dealing with the 3 segments. What is the proximal main branch, distal main branch, and the SB. I usually tell it 3 Caspers. And among these 3 Caspers, this third one, this side branch, actually defines that which type of bifurcation it is and how you will deal it, how much complicated it is. And this relevance also very much important for the side branch, whether you will ignore it or you'll have to go for the PCI. And that's why there is some controversy here, how it will be a relevant one, like more than 73 millimeter in case of non-left main one. And if it is more than 10% myocardium it is supplying, that side branch is relevant. But how much is the diameter, like more than 2.3 in COBIS 3, in Nordic 2, and definition more than 2.5 and 2.75 also in bigger trials, especially in left main. So coming to the thing is that whether it is a true bifurcation, whether it is a non-true bifurcation. And this nomenclature actually, obviously, angiographically, but also at the same time you can change the decision by imaging IVUS and OCT, also by physiology assessment, and which can put you that whether it is a true or a non-true one. So additional information you can get. But what I want to say, that I want to put this Spanish guy, the Alfonso Medina, the great claps, that he has made a very simplified definition and classification of the bifurcations. So these are the 7 types actually bifurcation is possible by these 3 Caspers, what we have told here. And then these lesions, I am telling, I'm in a bigger picture, see these 3 are true bifurcations. Like 111, 110, 011 and 101. This 3 is true bifurcation, though this third one, 101, is not the truest true, especially in complex cases. Because like in EVC main DK-Crush 5, this bigger landmark trial, they didn't include it as a true bifurcation lesions and a complex one also. And if you go for the rest 4 is the non-true one, non-true bifurcation. So the treating this one is possible. And to smell the complexity, then we have obviously the definition criteria. That is also a beautiful one. So the definition criteria is telling you have a major criteria and you have some minor criteria. So the major criteria for left main is that SB lesion length should be more than 10 millimeter and diameter stenosis should be more than 70%. This is one major criteria. And for non-left main, SB lesion length is more than 10 is okay, but diameter stenosis should be more than 90%. And minor criteria include 6 criteria like more than mild calcifications, thrombus, multiple lesions, angulation is less than 45 or more than 70, and also this reference diameter, the main branch distal reference diameter is less than 2.5 millimeter, and or thrombus containing lesions. And what we will say, 1 major plus 2 minor, if you have in the bifurcation lesion, then you will tell it is a complex one. Why it is important? Then you can alarm yourself that we have to be very serious while treating this case. From you have an upfront, there will not be ad hoc plan. That is the good planning you have to make for that one. So that's why this is important. Then comes to the approaches of treating the bifurcation lesions. There are some minute details here, because if you really want to talk, like when it starts, Dr. Guzman starts talking about this non-left bifurcation, he can take 2 hours even, because it's a huge subject. I'm telling some few minutes, like understanding the distal reference diameter. This is very much important, and the angulation, which he has started to tell, that angulation and the distal reference diameter, I'm telling again and again. This is very much important for bifurcation lesions. Wiring and rewiring when you will do the PCI of the main branch and the side branch. Jailing the wire, whether you will do it or not, and the wire wrap. Those very much silly thing, but it's very dangerous, because you have to start from the very beginning, maybe sometimes for this one. Port and KBI, these two, and also the choosing the stent platform. That is also important. Not any stand from the shelf. You have to be very much cautious about that one also. So you have to remember also Finner's formula. That is, I'm telling every time, because this is important. Because for left main, how much you will, the diameter you will do that one. You are seeing angiographically, it seems like that LAD is 2.5 and LCX is 2, but left main is looking 4.5 or something. It's not possible, because it's not like this. So D1 equal to D2 plus D3, 2/3 into 2/3. So by this way, you can judge that which diameter it is going to fit, and where it is going to fit, or whether it is left main to LED stenting or left main to LCX stenting, making it an inverted one or not. So this formula sometimes helps. And also the angulation, which was telling, and especially after wiring, if you see the angulation, that's better. Rejudge again. What is real angulation there? And also the beautiful thing has been, this name is very much important sometimes. In 16th DBC, they have told that the assigned SB means that in left main, LED is the distal main branch and LCX is the side branch. All the time it's like this, because it has been, LCX has been made for being a side branch, but not all the time in bifurcation PCI. When you will have to do an inverted technique, like doing a left main to LCX, at that time, LED has turned into a assigned SB, assigned side branch. So you have to remember that one also. Now comes to the wiring. Both main branch, especially in left main, both main and side branch wiring is very much important in true and non-true bifurcation. It is safe. Do that one. And also, additional wire you can take for rewiring. It's better not to pull out the jailed wire. That is very much important. And for wiring, the distal pullback technique is better and safe, because at that time you have no that sort of stress there, the whether the wire has been in between the stand and the wall. So pullback technique to wire the side branch is safe and better. Most important thing to remember, when you will rewire, never in the proximal crossing of the wire in the stand. You will rewire on the distal. And this distal crossing is the this distal crossing, distal strut crossing is very much important, except if you go for a decay crush technique. Otherwise, in all other techniques, you will have to go for a distal wiring. And I am telling the jailed wire, they put the wire in the jail. Don't think that it will, while you will pull it out, it will be torn out. It's a once in a blue moon phenomena. But keep the wire jailed, will help you in every procedural steps also. And sometimes modified jail balloon technique. This Professor Mir Jamal is here, he loves that technique. So to protect the side branch before occlusions. And then port, this port is the backbone of better bifurcation PCI. Like if you see this picture, where what is it is showing here, if you choose a stand according to the proximal MB diameter, then the left side picture will be there. So it will be overstretched distally. And it's not good. The carina will be shipped too much. You have to take the stent according to the distal reference diameter. And then you will do, and when you will do a distal reference diameter stenting, you see there is a gap. And this gap should be filled up by pot. So it is safe to take the stent like this, with this diameter, and then replenish it in the proximal part by a pot. So without pot, impossible to get a real bifurcation stenting. And that's why pot is important. And it causes strut malapposition reduction and open the stent cells for rewiring also. That's also important. And restoration of the circularity of the proximal vessel. So pot is important. How to do a perfect pot? Everybody knows it. You can see the picture here. Only thing is that in the proximal MB, there you should have an enough length so that in your shelf, what is the smallest balloon according to the proximal vessel size is there or not, because otherwise you cannot do a proper pot. It will go beyond the stent, causing some dissections there, or it will be beyond the carina, you will go down. So ultimately pot is not going to happen there. So you have to have that size proximal to the side branch to do a perfect pot. And the balloon size should be 1:1 of the proximal MB diameter. Then it comes to the kissing balloon. So it's another legendary one for bifurcation PCI. So KBI to be done after rewiring and through the distal stand start, except in decay crash. First thing, balloon size is very much important, which I see sometimes in some different cases. I see sometimes that you are putting a balloon of undersized or oversized balloon. You have put a stand there, but then you have to put the stands distal MB according to the 1:1 in both the distal MB and the side branch, not beyond that. Why? Because these two balloons will be in the proximal MB, a part of it. So if it is oversized there, then it will create problem in the proximal MB. The proximal MB will be overstretched. So that is not the issue here. And 12 atmosphere, not beyond 12 atmosphere for this. And in modified KBI, what you will do a sequential balloon inflation first, and then you will have to go for a simultaneous deflation. So that is the most important thing for KBI. And what I have told, the stand platform choosing. So these are the things that you can read in the stand materials, and you can understand that 1.5 to 2 millimeter more expandable stands it's better to take, because especially in left main. Now comes to the treatment strategy. Already he has told about Matt's classification inverted, and he will tell it again also. And I am telling about the distal left main is that there is a consensus there in 16th ABC also. Difference of opinions are also there too. But in a nutshell, two strategies. What is one? Is a stepwise layered provisional strategy, and there is a systematic or upfront two-stand strategy. But it doesn't mean that provisional means always single stand. It's not. It may end up with a bailout two-stand strategy. So when you are doing a bailout, it's also within the provisional philosophy, because you have the provisional philosophy first, but ended up in a two-stand strategy, like what happened in EBC main. Around 20% of the provisional stanting group has turned into a two-stand in left main. So that is possible. And for systematic or upfront, we have narrowed down the techniques like T or tap and crash, or different types of crash, which one you can choose, and the culotte. And what is provisional philosophy in detail? So I'm telling that one. Stand the MB or main branch, then do the pot, and finished. Your procedure is finished in the left main. Or you can go for a KBI, that means side branch opening you can do, and then done. It is finished. The provisional philosophy is finished, and provisional stand strategy is finished. Everything is Dimitri flow is there. Or if you see some problem in the side branch, then you will go for a bailout stenting. So that is the provisional philosophy. And among these two strategies, the provisional philosophy, obviously less metals, should have, in terms of TLR and MACE, should have the benefit than the two-stand strategy, which has been seen in this 12 meta-analysis of 10 observation and 2 RCTs. They have told that the TLR is less. But in real world, the complex two bifurcation lesions, like what we see in the EBC main and decay crash 5, they are telling that this is very much important, and they have positive outcome also, where you need to go for a upfront to stent surgery. Don't stick with the provisional philosophy there. So this is the thing. And then provisional philosophy, what I have told, that the KBI you will have to do or not, that means we tell it that you have stented the across, that means the left main and the LAD, and now it's a huge place there, and some of the stent materials are floating in the LCX. Whether you will go for a side branch opening or not by KBI, that is also important issue here. And here it has been told that eventual kissing is preferable sometimes, but sometimes it is not. When you will do a kissing balloon inflation, it will prevent the fenestrated restenosis. That's true, and give some good SB flow. But at the same time, in these trials like Nordic 3 and COVIS 3, they're telling there's no benefit at all. So whether you'll go for a KBI or you'll finish just by crossover stentings, that's the question there. And imaging what I'm telling, the role of IVUS in left main stenting, though it's a class 2A yet, but it's going to be a class 1, I can give you assurance that one, for left main especially. But in these two trials, they have only 40%. But again, this is true that this role is very much important, and you should go for it. And for physiology testing, FAME 2, they have told that obviously you'll have to go it, though Future and the fluorimide trial has got some, that it is not that much important, angiography and FFR, but those trials has got some problems and flaws there also. So role of physiology testing can help you saving a stent. So I want to finish here, I think. I don't want to see the cases or showcases the things. Now Dr. Guzman is going to tell about the non-left main, and then we can discuss again. Or I can show the cases, which I don't know. You can.
I stop in the case that you then.
Okay. Okay.